Welcome to Health and Harmony Beyond the Teeth, where we dive into all subjects that will help you become healthier and happier. As a dentist, I believe dentistry is more than just teeth, so I created this show to focus on overall health. We will hear from leading experts about eating better, exercising better, breathing better, and sleeping better. We want to help you create harmony in your life so you can live your life to the fullest. We want you to thrive. Hello, welcome to Health and Harmony Beyond the Teeth. I am Dr. Hal Stewart, your host, and it is an honor and a pleasure to be with you today. Today, I want to talk about a condition that is more and more prevalent. I would say it's even chronic and an epidemic in this country, maybe a pandemic worldwide. And it's sleep-related breathing disorders in children, adults as well, but I want to focus on children today. You know, what's happening with kids these days? It seems like more and more of them have behavior problems. They have allergies, they have chronic diseases, asthma, things like that, kids 40 or 50 years ago just didn't have. It seems like kids are taking more and more medications every day, and that alarms me. We see a lot of children in my practice, and we don't do pediatric dentistry, but my partner and wife, Dr. Corridor Stewart, and I treat children and develop their jaws and develop their airways. We do craniofacial remodeling, but we see a lot of these kids come in, and they're on one or more medications for chronic issues. These aren't medications like an antibiotic for an acute infection. These are medications like antidepressants and anti-anxieties and ADHD stimulant medications. And that is very concerning to me. Recent research has discovered that many of the problems that kids have, we'll talk about in a moment, they only may be symptoms of a very correctable deformity and dysfunction in the child's oral and facial structures. And we call this sleep-related disordered breathing. The scary thing is that a growing number of kids have one or more of the problems listed here. Bedwetting, ADHD, ADD, delayed speech, overweight and obesity, learning difficulties, vertigo, clumsiness, restless leg syndrome, aggression and defiance, teeth grinding, daytime sleepiness, nightmares, night terrors, allergies and asthma, teasing, bullying, and anxiety attacks, frequent illnesses, and stunted growth, just to name a few. But I want you to take heart. Recent research has discovered that many of these problems may only be symptoms of a very correctable deformity that we call sleep-disordered breathing, as I mentioned before. Only recently have researchers discovered that what the tongue does behind the scenes in the first years of a child's life could mean the difference between that child going through life happy and healthy and vivacious, or living a life of constant and chronic pain and illness and misery. If the tongue does not do its job properly in the formative years, the child's face and jaw may not develop properly. This in turn blocks or shrinks the child's main airway, and air doesn't flow freely into the lungs. And that means oxygen doesn't flow freely to the brain and body. This is especially harmful when the child is attempting to sleep, and we call this sleep-related breathing disorder. This is especially harmful when they're trying to sleep, this sleep-related breathing disorder. And one cardinal sign that your child might have a sleep-related breathing disorder is a condition where they're sleeping with their mouth open, as you can see here in these children and even in infant. Normal children have oxygen levels of 95 to 98% saturated in their blood when they're sleeping. That's normal, that's healthy. Children with sleep-related breathing disorders have oxygen levels well below that. In fact, oxygen levels in kids with sleep-related breathing disorder can drop down to 80% or even less. And this can cause permanent brain damage in children. So there are two types of sleep-related breathing disorders in children. Type 1 affects the airway in the throat, and type 2 affects the airway in the nose, as you can see here. These are the two primary areas in the structure of the face and mouth that become blocked because of the tongue's influence or lack of influence on growth and development. A few weeks ago, my guest, Dr. Ben Moralia, and you can find his series of episodes on my YouTube channel, Health and Harmony Beyond the Teeth. Dr. Moralia discussed the absolute importance and necessity of nasal breathing over mouth breathing. When we breathe through our nose, we get the perfect combination of oxygen, nitric oxide, and carbon dioxide. That is the perfect fuel for our body, and to properly oxygenate our body and take care of our cardiovascular system. When we only breathe through our mouth, we get unwarmed, unhumidified, dry air, non-filtered air, and we're much more prone to tonsil infections and adenoid infections, dry mouth, sore throats, and just shallow breathing. When we breathe through our mouth, we can take a lot of oxygen in quickly. So children that breathe through their mouth tend to develop asthma because they never use the lower third of their lungs. They breathe shallow and they don't use the full capacity of their lungs, and asthma sets in. If your child is sleeping with their mouth open, like you see on the bottom picture here, there's a really good chance that they have a sleep-related breathing disorder. Your child should be sleeping mostly on their back with their mouth closed, breathing through their nose. It should be very quiet. This is the sleep disorder breathing burglar, and he prevents children from getting good, restorative, and nurturing sleep by stealing away the child's oxygen at night. Because their brains and bodies are robbed of oxygen, things just go wrong. The oral and facial deformities that I mentioned earlier make up a disease known as sleep-related breathing disorder in children. Over the child's first 7 years of life, that chronic oxygen starvation, it may produce behavioral problems like we talked about before: ADHD, anxiety, bullying, learning difficulties, bedwetting, among many other comorbidities. These conditions are present in kids with sleep-related breathing disorders. The low oxygen levels suffered during sleep may also give rise to physical problems like delayed speech, delayed growth, crowded teeth, chronic fatigue, and sleep apnea. Thankfully, sleep-related breathing disorders are treatable. They can be detected early, and the earlier they are detected, the easier they can be treated. Now, this podcast today focuses on children, but even if they're teenagers, even in your 20s, 30s, 40s, 50s, 60s, we can still treat these. So better late than never. But I wanted to focus on the children today because we can do much more, much quicker, and save these children from a life of misery and chronic illness. Now, why treat sleep-related disorder breathing? Parents and teachers, counselors, and doctors may be diligently trying to treat a child's problem that really doesn't exist. They're treating symptoms. That's what ADHD. It's just it's a multitude of symptoms that, when combined together, put the child in an ADHD category. And unfortunately, the traditional Western medicine way to treat this is with medication. And that does not have to be the case. It might make the child a better, less of a behavioral problem at school, but it certainly doesn't help their learning whatsoever. And they're now on a chronic medication that they're going to have to be on the rest of their lives. Those children, they may have imposter conditions. I call it imposter conditions, which actually originate from their sleep-related breathing disorder because they're not getting nourishing sleep. Their brains aren't being nourished. Growth hormones not being released properly, and they just don't have that good, nourishing, rejuvenating sleep that they're supposed to have every night. And their bodies are oxygen depleted. That can make treatments intended to fix these imposter symptoms in reality unnecessary if we treat the root of the cause, which would be sleep-related disordered breathing. Some of the conditions that I see kids being tested for and treated for are psychiatric testing, psychotropic drugs are used, teeth are extracted because teeth are crowded and jaws are small. Some have to go to special education. Amphetamines are used to treat ADHD. A lot of these kids are in counseling and therapy. They're on ADHD medications. They're on allergy pills, HGH injections, behavior programs, et cetera, et cetera. For many children, these treatments are just long-term Band-Aids that manage their symptoms, but they don't do a lot or they don't do anything to address the root cause of the problems. So let's look at type 1 sleep disorder breathing. It's food for the mouth. In the 1950s, the availability of quick and easy, nutritious bottled baby food helped mothers get into the workforce very quickly. Today, we know that soft baby foods can actually weaken a child's tongue and their jawbone. Traditionally, foods that needed, active chewing, raw vegetables and meats that weren't pureed, they were introduced while children were breastfeeding still, and they were continued for 2 to 3 years. These tough foods, like raw vegetables, thick breads, crusts, chicken drumsticks, etc., they made the tongue and the oral muscles and lower jawbones work. After the Industrial Revolution, and especially, in the mid 20th century, the 40s, the 50s, all the pureed baby food came out, and kids they basically didn't have to work to chew their food anymore. And so why is this so important? Well, when a child breaks a leg, the leg is, have a cast put on it. And soon the bones and muscles begin to shrink because of the leg is not used. The leg can't move, so it's fooled, or the brain is fooled into thinking that it's really not needed. It's got a cast on it. You really can't use the muscles and that leg anymore for a while, so it starts to shrink. To counter this, doctors soon will put the leg into a walking cast. This stresses the leg bones and the muscles, and they respond by growing stronger. Well, that doesn't happen when we're eating soft food all the time. The soft foods like mashed potatoes, applesauce, pureed peas, and corn and vegetables, they're already pre-chewed for the child, or the child simply swallows the food. So those muscles and bones in the jaw and the facial complex don't get used. No chewing pressure is put on the jawbone at all. So like the boy's casted leg, or the child's leg that's been casted, it doesn't grow. The tongue isn't exercising by positioning food for the teeth. It doesn't need to. It's just soft food. They put it in their mouth and they swallow it. So the tongue gets weak. The bones don't get stimulated. The muscles don't get stimulated. The jaw and the tongue don't grow, and they may even shrink some. The rest of the head keeps growing and develop normally. So here's a child with a stunted chin. There's 2 examples here of stunted jaw growth. Notice the very weak the very weak chin in the child, the toddler at the top, and how that translates into the teen and early 20 years in the picture of the young lady below. This is a direct stimulation, or direct lack of stimulation, of the oral musculature and the bones in the mouth. So there's a simple test, mom and dad, if you're listening to this, that you can do at home to evaluate your child's chin. Take a profile photograph of your child, like you see here. Try to get it close up so you can, blow it up kind of big on your computer screen, and lay a ruler at his forehead, his or her forehead, where you see the top arrow. Run the ruler down the edge of the ruler down to the point where the upper lip meets the bottom of the nose, as you see in the bottom red arrow. And if your child's, and then the ruler continues on down. If your child's chin is touching the edge of the ruler, or you see there that black line, the far left black line, that's good. But if there's a gap like you see there and the chin is behind that line, that's a recessed or a underdeveloped chin, and you need to have your child evaluated by a professional. If you're not sure, another indicator is if the child's cheeks may look too big for their chin size, like a gopher cheeks, real puffy like you see here. Just a quick qualification, a quick screening device that you can do at home. People may try to convince you that your child's stunted chin is merely hereditary. Oh, he has your dad's chin, or he has his mother's chin. What they may not point out is that maybe mom or dad suffer from sleep apnea. Maybe their chins never developed correctly either because of these effects of poor nutrition and things like that we've talked about. They may say that your child will grow out of it because all children have receding chins. That is just not true. Don't let anyone tell you that. The truth is that a stunted chin usually indicates that the child's tongue and the lower jaw failed to grow properly, failed to go forward, and now they may be constricting the airway. You can do a simple assessment to see if your child might have a sleep disordered breathing besides the one that I just showed you. Have your child face you straight on and look you in the eyes, then have them open their mouth as wide as they can and place the tip of the tongue on the back of their lower front teeth, like you see here. They don't stick their tongue out, just on the back of their lower front teeth. Compare your child's airway to this diagram. Choose the one that best matches your child. If you choose number 2, 3, or 4, you should be concerned and you should speak with a qualified children's airway professional like myself, because your child might be suffering from a sleep-related disordered breathing. Remember, even if the jawbone and the tongue stop growing, the rest of the head, and they keep going around them, this then closes the child's airway off. The larger the child gets, and the chin and the jaws don't develop, the smaller constricted airway they have. Also remember that if soft baby food has made the tongue weak, then it may be falling backward into the throat as well, and that could cause sleep apnea. We have several patients that are not even 10 years old yet that suffer from sleep apnea. So what does sleep 1 or type 1 sleep disorder breathing feel like? Well, you can do this on yourself with your thumb and forefinger like this. Open your mouth and push your chin back like that, and push it way back, and then just breathe. Try to breathe through your nose. Try to breathe through your mouth. It's not very easy. A lot of fun, isn't it? If a child develops that way, that's all they know, and they're suffering from that. So if your child is breathing with their mouth open when they're sleeping, if they're walking around the house or doing their homework or watching TV and they've got their mouth open, they can't breathe right. They can't breathe correctly. If you listen to them sleep and watch them sleep, and they're restless and they're noisy when they sleep, and they drool or they wet the bed, there's a very, very strong indication that they're not sleeping well and they have a sleep-related breathing disorder. Fortunately, qualified children professional, airway specialists and jaw growth specialists like myself, we offer programs that can, if started early enough, reverse the effect of irregular facial development. Using guided growth or guided growth guides, children can be successfully treated for a narrow airway. The child's facial structure, their lower jaw and tongue are gently returned to a normal developmental track. In addition, we work on training the tongue, promoting proper swallowing, improving speaking skills, eliminating thumb sucking, and eliminating tongue thrusting. So you can see on the top diagram, a restricted jaw, restricted airway, and after guided growth. There are several different ways to do this. We use fixed expanders, removable expanders, growth guide mouthpieces if the children are young enough, that are worn while the child is sleeping, that helps their jaw develop. So let's now look at type 2 sleep-related breathing disorders. Like I mentioned early, in the 1950s, the economy was booming and women were needed in the workforce. And so with the arrival of some new products called pacifiers and baby bottles, women were free to respond, and they did this in droves. In fact, some of the pacifiers and bottles were a key factor in creating the two-income family. The added income that this provided improved nutrition and education and the health of babies everywhere. However, unbeknownst to doctors and scientists at the time, these items also began to change structure of children's mouths. Pacifiers and bottles are still in use with us now because of their value to families. But we need to be aware of their downfalls because there are many. Imagine the red circle above is a thumb, or a pacifier, or a bottle nipple. This is inside a child's mouth. When the child sucks on it, the cheeks and lips are pulled in, forcing the upper gums inward. The tongue also pushes the object into the roof of the mouth, whether it's your thumb, whether it's a pacifier, whether it's a bottle nipple. So it gets pushed into the roof of the mouth. This causes a force or pushes up against the nasal airway passages, because the floor of the nasal airway passages is the roof of the mouth. It's the same bone. Meanwhile, the sides of the tongue are also being forced outward against the lower gums and pushing them apart. It's been estimated that 18-month-old babies spend as much as 85% of their waking hours sucking on something. So, isn't breastfeeding sucking as well? Well, actually, it's not. Yes, the tongue does push the breast nipple up against the roof of the mouth, and it causes the mother's milk to be pressed out, and rather than the baby sucking it out. So you see here in this illustration, as the baby continues to apply upward pressure over and over, the tongue also pushes outward when the baby is on the nipple and not on a bottle nipple or on a pacifier. The repetitive motion means that the tongue resists the inward pressure of the child's cheeks, and it pushes outward, and it protects the nasal airway because it's not pushing up against the roof of the mouth, thus narrowing the airway. Protect the nasal airway. What does that mean? Well, the roof of the mouth, the child's upper palate is the roof of the mouth. It sits right underneath the airway. As I said before, the floor of the nasal passage is the roof of the mouth, the same bone. It sits right underneath the airways, coming in through the nose and leading into the lungs. If the roof of the mouth gets squeezed, it will get pushed up into the nasal airways. When that happens, the nasal airways get squeezed and become more and more difficult to breathe through the nose. And I've already mentioned how important nasal breathing is. Pushed up into the nasal airways. Again, let's give an illustration. The cheeks and lips are powerful muscles, and they constantly squeeze inward on the upper gums. Sucking on objects just adds enough extra pressure each day to raise the roof, so to speak. The vertical black line you see below, above are the same height. The two horizontal lines are the same width. As you can see, squeezing the orange makes it taller and narrower. So think of that as the roof of your mouth, and think of the fingers and the palm of the hand that you see there are the muscles of the cheek and lips of this patient. So as we squeeze, the orange gets taller and narrower, And the tongue fights that inward pressure by swallowing 13 to 1600 times a day, including when the child sleeps. So when a child swallows, the tongue presses up against the roof of the mouth, presses up, and it starts a wave-like motion that moves back and down the throat. As it does this, it pushes out on the sides and the upper palate to form a seal. That constant interaction counteracts the inward squeeze of the cheeks and lips. So if the tongue is not functioning properly, we're not going to get this protective scaffolding mechanism to help the jaw grow. So normally the child's tongue is up in the roof of the mouth, as you see on the top diagram. There it pushes outward each time the cheek and lips squeeze in. In fact, every time the child swallows, it pushes a little harder so that as the child's head grows, the upper palate expands outward. If the tongue is not up against the roof of the mouth, as you see there in the lower diagram, the child will develop a tongue thrust. Swallowing motion in this adaptive motion isn't very effective at countering the cheek and the lip muscles' constant squeezing inward. And so we get a narrow upper jaw, we get a high vaulted palate, and we get a reduced nasal passage. So you might ask, why wouldn't the tongue be in the roof of the mouth? Well, it's either too small or it's too weak or both. Remember earlier when we learned that soft foods make the tongue and the lower jaw shrink and become weak? Well, sometimes the tongue is physically being prevented from being in the roof of the mouth because of a tongue tie, or we call that ankyloglossia. And a qualified doctor or dentist, such as myself, can remove the tissue and free the tongue. I did a surgical residency with Dr. Sarush Zaghi to learn how to properly and effectively do tongue release surgeries on children from age 3 up through adults. I've done 3-year-olds, I've done 70-year-olds. And it can make a huge difference. I've been performing these release surgeries now for several years, and my wife, Dr. Adriana Corridor Stewart, performs the surgeries on infants and up to children of up to 3 years old. The results have been nothing less than remarkable. So let's look at reason number 3 for poor breathing. I call it the stuffy nose cycle. Sometimes mouth breathing begins with a simple illness. A child catches a cold. Before he or she can recover from that cold and virus, another one hits home, and then he or she develops a sinus infection, which eventually takes 9 weeks or so to get rid of. By that time, the child has had a stuffy nose for months and adopts a mouth-breathing sleeping style. The child's mouth breathing disrupts their sleep. Mom soothes the child by giving him or her a pacifier. The child also gives the mother gives the child extra bottles to keep her hydrated. The mom puts a pacifier in the child's mouth to help the child sleep. The child then spits it out so he or she can keep his or her mouth open for breathing, because breathing is the highest order. You're going to do anything you can to breathe. Mom puts it back in her mouth, then she spits it back out, and it's just a vicious seesaw battle. Even if the child's nasal airways eventually open up when they get well again, the tongue now has learned to lie on the floor of the mouth, and air coming through the mouth isn't moistened, it's not warmed, it has no filtration, no nitric oxide is being placed into the air like it would be if you're breathing through the nose. So you're getting cold, dry air, and that irritates the throat and the tonsils. So a lot of these kids have swollen tonsils. Eventually, the child forgets how to breathe through their nose. The mouth becomes to hang open throughout the day. The tongue tries to get the body as much oxygen as possible, but it does this by lying on the floor of the mouth where it won't get in the way of the incoming oxygen, because the child is not a nasal breather anymore. So they're getting air into their lungs like a fire hydrant, spewing out water, and they only take shallow breaths. They don't breathe deep nasal breathing. That's very healthy breathing. Because the child is breathing through their mouth, bacteria, viruses, and allergens don't get filtered out by the nose like they should. And the child develops chronic illnesses like sinus infections, ear infections, allergies, and asthma. And the illness merry-go-round goes on and on and on and again and again. And we see it every single day. When the tongue is not living in the roof of the mouth, as we've discussed, the upper jaw gets squeezed together. Then it not only raises the palate, or the roof of the mouth, and constricts the nasal airways, it also squeezes the upper gums inward. That doesn't leave much room for the adult teeth to eventually emerge, creating what some kids, or some mean kids in school, will call vampire teeth. So if your child has crowded teeth, their jaws are too small. There's no doubt about it. Guided growth techniques, as I mentioned earlier, are used for type 1 and type 2 sleep-related breathing disorders to reshape the roof of the mouth and open the nasal airways. Tongue exercises strengthen it and get it into the roof of the mouth. We use myofunctional therapists for our children and adults to help strengthen their tongue, to create tongue tone, proper lip and cheek muscle use as well. The upper jaw will expand so the adequate space will be available for the upper adult teeth to come in, and the upper and lower teeth will mesh together in a solid and functional bite. The child you see above, Chandra, has just started kindergarten on the left side and was having some troubles in school, ADD or ADHD, some behavioral problems, focusing problems. She was a mouth breather, and sometimes she choked during sleep. After being treated with a guided growth program, Chandra's lower face and jaw began to fill out, and she found it easier to breathe through her nose. She began getting the restorative and rejuvenating sleep that her energetic body demanded. And you can just see the difference in her picture on the right several years later. So by now, Mom and Dad, you're probably asking, does my child have sleep-related breathing disorder? Or how will I know if my child has it? Well, I gave you a couple of screening tools earlier. If your child has one of the symptoms that we had talked about, if they're snoring, if they're struggling to breathe, if they're breathing noisily, if they have crowded upper or lower teeth, if they have a stunted chin, if they have dark circles under their eyes, if they're mouth breathing and eating with their mouth open, if they have dry and swollen tonsils, or any of the other things that I mentioned earlier, ADHD, if they're wetting the bed, their sleep should be, think of Dairy Queen Sunday, DQS, dry, quiet, and still. When a child sleeps, there should be no moisture. There should be no drooling. There should be no wetting the bed. They should be quiet. You should not be able to hear them breathe when they're sleeping. And they should be still. They shouldn't be restless. When you come in the morning and their sheets are all over the place and they're laying down at the foot of the bed, something's wrong. So where do we go from here? The good news is that whether your child is just beginning to show signs of sleep disordered breathing, or if they've done so for years, or if you have those symptoms, there is help available. The bad news is that sleep disordered breathing in children is such a new concept, though it is well researched and it is scientifically proven, that many physicians and airway dentists in general, they're not yet aware of it or the available treatment options. That's why your most important job as a parent right now is to make an appointment with a pediatrician or a dental airway specialist, such as myself, a craniofacial development specialist. And if needed, introduce them to sleep disorder breathing if they don't already know about it. But if you seek out those that are already specializing that, such as myself, There's more. I see more and more pediatricians that are starting to pay attention to this. Then ask them to help your child get proper treatment. If you have a pediatrician that is not well versed in this, or a dentist that's not, help them help you find someone. So now that you know about sleep disorder breathing, you're going to be more aware of tired children standing in the background with dark circles under their eyes, stunted chins, crowded teeth, open mouths, and kids that just aren't thriving. And, we can help these kids. There's so much that we can do for them. And on a personal note to all you parents out there listening to this podcast, take a deep breath through your nose, preferably, and know that you cannot do anything to change your child's past or your past up to this point. But you can certainly do something to transform their future. So if you have more questions, or you'd like to have your child or yourself evaluated, give us a call. My office number is 972-874-3957. Our website is the Stewart Center for OptimalHealth.com. If you're from out of state, we have a lot of patients that fly in. We're right close to DFW Airport. We actually have a part of our website deals with patients that come in from out of state and all the information they need. But if you can't make it here, give us a call anyway. We can maybe help you find a professional that can help you. So it's going to be okay. Don't panic. Just know that you have the power to change your child's future. I hope this has been informative for you, and this has been a pleasure for me to be able to share this information with you. This is Dr. Hal Stewart with Health and Harmony Beyond the Teeth. Have a great day, and I'll see you next time. Bye-bye.